My name is Madelyn Esposito. My pronouns are she, her. I'm a program manager for the Sexual Health Clinic, like was already mentioned. And the Sexual Health Clinic, to clarify, it's a sex therapy clinic that's going to be integrated with a new program called Integrative Specialty Care for Women. And so this program, the Sexual Health Clinic specifically, will be working amongst not just people with vulvas, but also people with penises, trans folks, intersex folks, everyone's a sexual being. And so the clinic will be open to everyone who has an interest in expanding their sexual health. Some key terms to get started that I will toss around today quite a bit. WPATH, this is actually is updated. There's a volume 8. And WPATH is my standards of care. So when I'm writing letters for clients that want to go through top bottom surgery, I'm using their standards of care to be able to substantiate the psychological need for that surgery to take place. Transgender is an umbrella term that encompasses all people who identify with a different gender than their assigned sex at birth. Cisgender or cis, people who identify with their assigned sex at birth. Agender, not having a gender or identifying with a gender. Non-binary, so not describing oneself as a specific gender or having an identity that doesn't fit into male or female. And sometimes my clients refer to themselves as genderqueer when they identify as non-binary. And then gender fluid. And these folks that I work with, they have a gender identity that shifts between or outside of societal expectations of the binary male or female. So when I'm on Facebook and I'm seeing gender reveal parties, all of these terms come to mind for me because it's less of a gender reveal party and more of a genital reveal party. So here is a gender unicorn, and this is one of my favorite tools to use with my clients as they're exploring gender identity, gender expression. It's also just really, it's just a great demonstration of how complex sexual and gender health is. So you'll see how gender identity is a component, and gender identity and gender expression are quite different. I've worked with women who come in and they have not transitioned and they come in looking like a cisgender man, and they still are she, her. We have sex assigned at birth, so female, male, other slash intersex, physically attracted to, and emotionally attracted to. Sexual attraction can look very different. And so this also captures how you can be emotionally attracted to certain people, but then also physically attracted to others. This is a really fun resource online, and you can actually move the dials. And this can change as well with time. Language is incredibly important. I consider how I use words that reinforce a gender binary. Parent versus mother, father. I had a client whose sibling was having a baby, and I mistakenly called them aunt, and I had to like bring it back and say, wait a minute, you're gender non-binary. What are you going to call yourself? And then ask more questions about that because we don't have another word really other than aunt and uncle. And so getting to ask those questions of like, what are you wanting to be called? How are you going to introduce yourself to this child? I've worked with folks that breastfeeding brings dysphoria, so they prefer chest feeding. Mankind versus humankind, you start to see these gendered terms wherever you go. And these are just a few examples of that. Whenever possible, I try to avoid using men to reference people with penises and women to reference people with vulvas. If I'm running a training where it's specific to men or women, I'm very clear at the beginning of what I mean when I'm using that term, so that folks understand that when I do reference men, I mean this, and when I do reference women, I mean this. It used to be when I was learning how to do sex therapy was maintaining really strict professional boundaries and using the appropriate medical terminology when talking about genitals. Now there's recommendations that sex therapists, clinicians use a patient's preferred names for their genitalia. And this is the only exception when I'm working in sexual health. I strive to use medical terminology because I don't think it's normalized enough. I think we rely a lot on slang. One of my favorite exercises is to have people name off all of the slang they can come up with for vulvas, and then all the slang they can come up with for a nose. And you'll see quite a stark difference in how many slang words people have for genitalia due to the discomfort and the stigma. And so historically, as a sex therapist, it's been use the appropriate genitalia to help normalize. But what I have found with my trans folks is that it can bring dysphoria. Like their genitals don't feel necessarily like a binary. And so using their terminology can help create a safer space for them. I make every attempt as well not to have my clients be the educator in the room or be the expert in the room. They're the expert of their lives. And I do and will ask questions for clarification or to get their understanding of how they might define something. But I'm not going to be probing my client in front of me to explain something or educate me. It's my job as a clinician to do my own education. And then I can come back and say, hey, this is what I read. Does that feel true to you? Because my goal is to help my client, not to help myself, not to help myself learn. And this is the same as well when I'm in work meetings or I'm in trainings, is really striving to not put this undue burden on trans folks to educate. Like they are there to also learn unless they've initiated themselves to be in that role. Last on the slide is this notion of passing. And passing is this term that implies whether someone is perceived as man or woman. And many of my clients do strive to pass because it will bring a sense of safety to them. They feel more able and safer to use a public restroom, for example, because they pass as the gender of the restroom that they're using. There is complications though with using the concept of passing because it does imply that looking cisgender is this goal and that anything other than that is them trying to trick us, trying to dupe, that they need to convince others of their gender identity. Well, like I mentioned before, I've worked with transgender women that come in and they are expressing themselves as cisgender men due to safety concerns. And that woman in front of me is no less a woman. So when we're talking about pronouns, it's no longer preferred pronouns, it's just pronouns. They've simplified it because this is just someone's reality, not their preference. I share my pronoun verbally and in writing, although I do identify as cisgender, just to promote inclusion, as well as to welcome other folks to share their pronouns. That way, if someone is transgender, they're not necessarily outing themselves. I'm also sharing my pronoun to help create safety in the room. And then abstaining from disclosing someone else's gender identity. So there's a big safety component here. When I'm working with someone who's transitioning, and they're really excited to start talking about their pronouns, I'm very clear about, well, who are you telling and who are you comfortable with me sharing this with? Are you comfortable with me using your pronouns in your medical chart? Do you want your pronouns updated in your medical chart? Do you want your preferred name on your medical chart? When I walk you out, how would you like me to address you in front of my schedulers? Because transitioning can be quite a process and can bring a lot of fear, and wanting to make sure that my client is in a place of wanting to disclose. And they also may not be ready to disclose to their medical providers as well. And so wanting to be clear that therapy can be a space where they process it without necessarily having to come out to everyone on their care team. Here are some examples of pronouns. There's a lot. And so asking folks like, hey, how do you identify? These also can change. I've worked with clients that initially are they, them. And then as they transition, they're like, you know what? I feel more as a he, him. And I go with it. Whatever they tell me, I'm going to respect and I'm going to do. And I will make a mistake. And so here's where we are with mistakes. I make mistakes all the time and I have good intentions. And so when I make a mistake, maybe I misgender someone, I apologize. Like, I'm so sorry. Like, I meant she. And then trying to avoid redirecting focus to yourself. Wow, I'm such a terrible person. You know, I took this training the other day and I should know better than that. That really does put that person in an awkward position of then feeling like they have to help you feel better. Just listen and take accountability and then just do better next time. And that's, as long as you have good intentions, clients and patients are going to feel that and they will know that. There's quite a difference between someone making a mistake and making a microaggression, which is where someone is more intentionally hurtful and trying to belittle someone's gender identity. As a clinician, I welcome my patients if they're comfortable to explore gender expression during visits. Of course, considering safety. So some of my clients, they change clothes in the car because they feel more comfortable wearing a dress to clinic, but they also may come from a rural area and not feel able to wear that dress in their communities. So I like to encourage gender expression, and my schedulers are also very inclusive and are just fantastic. And so I also work in a culture here at UW where it's very welcomed. Gender flux fluid. This is, I already mentioned something. Sometimes my clients prefer different pronouns depending on how they're feeling. This is a valid experience and I'm going to go with it. If I can make them feel comfortable, that's much more valuable to me than trying to prove a point or trying to pathologize them. If they're comfortable in therapy, they're going to get a lot more out of it. And then embracing everyone's own gender identity and their own journey. Gender does not require affirming surgeries or hormones or social transition. There's many factors that come into play, and I list some of those out in a later slide that may impact someone's comfort, safety, you name it, and why they choose not to pursue gender affirming surgery. There's risks to surgery. There's financial risk. Some of my clients are in this place of feeling that they have to choose between having surgery to get a penis that they can use to urinate from, or having a penis that they can use during sex, and they feel like they have to make a choice. And for some, they do. And so there's many decisions that come down, and clients may or may not choose to pursue them just out of risk, or maybe even just wanting to wait until time tells when there are new procedures that are available to them so they can be able to have the body that they should have been born with. And then, of course, going back to gender unicorn, gender identity doesn't indicate sexuality at all. Sexual orientation and desire, it might shift with hormone therapy. I have seen that happen. I've seen sexual interest change for some of my clients. And by sexual interests, I mean like kinks, maybe things that they'd be wanting to try with a partner, as well as their sexual orientation might change. And these are things that I help people like process as they go through these, as well as giving them a space to explore and discuss that without judgment. I don't ask intrusive questions regarding genitalia unless it is medically or psychologically indicated. Every time I'm asking a question in therapy, it has a reason behind it. And if the reason is my own curiosity, then that's not an appropriate or ethical question to ask. So when I'm talking with someone, I'm not asking them, hey, what do your genitals look like? Just because I'm curious, like that's intrusive and that's violating. I'm asking questions about their genitalia if I do think that it's required, if I do think that it's relevant to our work in self-esteem or surgeries, or just wanting to get a good gauge of how dysphoric they are. And so I come back to being really thoughtful in how I talk about their bodies. There's a big safety component, and this is especially true when I'm working on when I'm writing a letter for surgeries. I'm thinking about safety. So what are the positive and negative consequences to transitioning right now? And who are their support systems? You know, they haven't come out, what's going on with that? Why not? But being really open and non-judgmental as to why they haven't come out. There's a lot of reasons why people don't come out until later in life. How will they know if or when, or to whom they'd like to disclose their identity? One thing I've seen is, especially with young people, they start to come out, and then they start coming out to everyone. They get really excited. And then what can become problematic is they start to come out to people that are less than kind, that are a bit judgmental, and that really throws them for a loop. And so I try to be very thoughtful when I'm working with clients of how do you know when you should come out to someone? How do you know that it's safe? because of the fear that they will over disclose to people, and those people will not be supportive, and then that would really take a toll on their mental health. And then would surgery improve their sense of safety? Would it help them feel like they can use the bathroom that they identify the most with? And of course, like, this is all on top of the social, political, and financial impact of being transgender. Like, being transgender is complex trauma, it's chronic stress. It's living in a body that doesn't feel like your body, being trapped in something that feels less than congruent. Looking in the mirror and being shocked at what you see because you thought that you looked a different way. And then you have these triggers on top of that. You have the medical and legal system that tries to dictate what you can and can't do to feel better in your skin and in your body. And you have the socio-political climate that increases hypervigilance, even restrooms. And in my work as a therapist, I've worked with families where a parent is transgender, and I've had to facilitate conversations with their children. If I'm in the bathroom and this happens, here's what I want you to do to keep yourself safe if I'm attacked. And it's a very real thing. People that are transgender also have children and families that are impacted by these socio-political stressors. And so my role is to help mediate conversation of how can we keep everyone safe. And this even comes down to people being really strategic on like which stores they go to, which stores are most inclusive, what states are more inclusive. And then this is punctuated by the financial burden to transition. It's very expensive. Some people choose to work in less than desirable jobs because the insurance covers transition. Some people don't have insurance at all and are unable to transition. And the impact of being transgender can be incredibly acute to the point where I've had colleagues whose clients try to create their own medical interventions to remove their genitals. And that is how acute this dysphoria can feel. So it's absolute discomfort or distress with having a body that misaligns with your identity. It can be generalized to your entire body, or there are specific body parts. Some of my clients describe not being able to shower. They won't exercise because if they exercise, they don't feel comfortable in their body, but then they also would need to shower afterwards and they don't want to have to shower. So they avoid sweating because they don't want to take their clothes off. They don't want to use the restroom. So some of my folks, like, they will hold in urine all day when they're at work. They won't have sex, or they abstain from having sex in different positions because they're so insecure about how their body looks. They have this strong dysphoria, as well as social interactions, agoraphobia, social anxiety can also intersect with dysphoria, not feeling safe or comfortable being out. And then to cope with the dysphoria, you'll see a higher likelihood for other mental health conditions. Depression, there's the social phobia again, anxiety, alcohol and drug abuse. I have seen clients that come out as transgender in older age who have been using substances their entire life to cope with this dysphoria. And so it can't be understated how dysphoria punctuates this experience of being transgender. For some, it gets better with therapy, with self-help, with gender affirming procedures. I also like to normalize with my clients that even after a gender affirming procedure, dysphoria may still linger, and is still something to be conscious about. On top of dysphoria, you also have euphoria, which I didn't address here. And euphoria is something that happens when clients feel really great in their skin as a transgender person. And this can help increase energy and motivation to do all the things that they would like to do. And so here's some resources. Trevor Project is one that I use quite a bit for my clients that are trans that are also experiencing acute safety risk. And I also use here in the Madison area outreach. And so there's great resources as well as books that are available for clients that are exploring gender as well.